I'll start with this, the most common mishap and most dreaded mishap that we can ever do in managing infectious uveitis. The example already shown by Sir in the last talk. This young female presented to us with necrotizing retinitis in the right eye, almost entire fundus involved. The vision was counting fingers. She had already been treated elsewhere with anti-TB therapy and steroids. And the worst thing that happened to this patient was she had received intravitreal triamcinolone in this eye that led to this necrotizing retinitis. Now, what we could establish by diagnostic PTV in this eye was the toxoplasma gondii cysts could be detected in the vitreous biopsy by cytology. And this is how she responded immediately at 1 month to dramatic response following anti-toxo treatment. What went wrong with this patient? This was the lesion that she actually had when she presented to the treating ophthalmologist, not realizing that she had toxoplasma uveitis, and the intravitreal triamcinolone acted like fire and that burnt the entire fundus. Another case, a 70-year-old man with right eye significant vitritis, cells, raised pressures, some HSV serology positive somewhere, and patch of retinitis. So thinking of a viral uveitis diagnosis, the patient went on to receive antivirals with no response with steroids, and at 6 months he undergoes vitrectomy where again the toxoplasma gondii cysts are detected. So this was a case of toxo and not viral, and we get carried away by some of the clues like raised pressures and all. So we need to be aggressive in these cases and establish a diagnosis histopathologically or by molecular diagnosis. So this patient was, however, lost to follow, but we could publish this case in the ocular immunology information. My third case is an example of a 37-year-old male presenting with left eye decreased vision since 1 week. His vision was 636. You can see very well there is disc edema, and the fluorescence shows disc edema in the left eye. The left eye had RAPD. There were few cells in the anterior chamber. A probable diagnosis of acute anterior ischemic optic neuropathy was made. Possibility of sarcoid was also kept in mind. He underwent investigations, but not very conclusive. We get carried away by the perimetry, which reveals inferior altitudinal defect, and a diagnosis of AIOM is the working diagnosis of this patient, and he started on steroids. Not realizing the eye is getting worsened, 15 days later, the hemorrhage appears on the disc. There is increase in the peripapillary fluid. The cells have now increased to 2+. The vision is not improved. He's worsening, and when we see the fundus, this is what we find, that he's actually developing progressive outer retinal necrosis. So it's imperative to examine the periphery of these eyes, where we can miss by the subtle signs like few cells in the anterior chamber or in the vitreous. So this is how he progressed, and we took an AC tap, confirmed our diagnosis. The PCR was positive for VZV, and at the time the diagnosis was revised to progressive outer retinal necrosis. This is how we responded to the antiviral treatment. Fourth case is just to highlight that the peripheral examination is must. The vitritis and some of these lesions in the posterior pole may not give clue unless we see the periphery like this, because these lesions are very fast to progress, and the other eye also we may see these lesions, but it's important to see the periphery, and this is how the patient progresses. My fifth case is a young female who had decreased vision since 6 months. She was being treated as TB choroidal granuloma at a center in Delhi. However, poor response for 6 months made the clinician think of possible enucleation, because possibly there was an intraocular mass. When patient came to our center, she underwent a diagnostic PPD, where the vitreous and subretinal fluid samples were subjected to cytopathology PCRs, and the PCR was positive for TB. Gene expert detected rifampicin resistance. So it was not a case of intraocular mass, which was requiring an enucleation, but it was a case of TB granuloma, which was multi-drug resistant. So she received MDR TB therapy, and this is how she healed, and we could avoid an enucleation in this eye. Sixth case, again, a young female. You can see these scars here in the posterior pole. She was being treated for 3 years before she presented to us. She was also diagnosed to have pulmonary TB in 2005, and she came to us in 2008. So during these 3 years, she was possibly thought of as TB granuloma, and she received anti-TB therapy at Center 1 somewhere in Delhi. with steroids, and then the serology for IgG was positive for toxo. Anti-toxo treatment was added. She didn't respond much. She goes to another center where Imuron is added for a possibly working diagnosis of macular serpiginous choroiditis. She doesn't improve. She goes to another center where mycophenolate is added. She worsens. She develops systemic symptoms. There was disc edema with headache, and possibly TB meningitis diagnosis was made by the physicians, and again ADT was restarted. So during these 3 years, she had visited a number of hospitals, almost 18 specialist opinions she had sought, including pediatrician, physicians, ophthalmologist, chest specialist, and neurologist. And although she recovered from meningitis, and somewhere in the records, it revealed that active choroiditis patch was seen with some intraretinal hemorrhage in 2007, and which probably this clue was missed by the treating ophthalmologist at that time. And for this, she received a posterior subtenon steroid injection, which worsened the scenario, and she developed recalcitrant glaucoma, requiring glaucoma filtration surgery. When she came to our center, the fluorescein revealed inflammatory choroidal neovascular membrane, for which she received intravitreal bevacizumab, and we could maintain her in remission for almost 3 years. And she showed recurrence only once in 2012, where she was treated with anti-toxo treatment, and we've been able to maintain her for 6 years with this scarring and a quiet eye. So hypopyon uveitis, sometimes it's a straightforward case, sometimes it can be deceptive unless we dilate. These are 3 different situations. So we need to dilate them and look for clues, like if we see exudates in the vitreous, yellow glow, we know what we're dealing with, probably an endogenous endophthalmitis. The pupil dilates, lots of synecdoche, the media is clear, we're dealing with a lot of congestion here, we're dealing with acute anterior uveitis, and we look for the mobility if the hypopyon is shifting, and additionally we see vasculitis on FFA, we're dealing with Behçet's uveitis. So diagnosis of infectious uveitis, when we are actually dealing with non-infectious uveitis, is another mishap which I'm actually be covering in my subsequent talk. So to summarize, the top few mishaps in managing infectious uveitis are the use of intraocular or periocular steroids to treat infectious uveitis. They add fuel to the fire. Limited fundus examination, missing out on peripheral lesions is another mistake that we make. We're sometimes missing the subtle cellular reaction and diagnosing a non-inflammatory condition. Hypopyon uveitis, under right circumstances, these can be distinguished very well, but if a mistake is made, we can have serious consequences. Missing out subtle clinical clues of sequelae, not only active inflammation, but sequelae like inflammatory CNVN, as we saw in one of the cases. PPD positivity and ocular masquerade, not easy, but we have to see the clinical signs. Relying solely on serological tests when the clinical picture tells you otherwise, and continuing empirical therapy despite poor response for weeks or months, and waiting too long for a diagnostic procedure. Thank you very much.